We proceed then to examination of the deep reflexes. We start by examining the deep reflexes in the upper limbs. The commonest deep reflexes routinely elicited in the upper limbs are the brachioradialis reflex, the biceps reflex, the triceps reflex, and the finger reflexes. The brachioradialis reflex is done while the upper limb kept in a position of flexion at the elbow joint in an obtuse angle of about 120 degrees, and the forearm is put in a position of slight pronation. And we tap upon the brachioradialis tendon while observing the contraction of the brachioradialis muscle and the tendency at flexion of the elbow joint. We elicit the biceps reflex while the arm kept in the same position. The biceps reflex is elicited on the right side by putting the index finger upon the biceps tendon in the cubital fossa and tapping our own finger while observing the contraction of the biceps muscle and the tendency at flexion of the elbow on eliciting the reflex. We repeat the biceps reflex on the opposite side by putting the thumb upon the biceps tendon and tapping it with the hammer while observing the contraction of the biceps muscle and the tendency at flexion of the elbow. The triceps reflex, on the other hand, the triceps reflex, on the other hand, is elicited while the patient's arm kept in a position of flexion at the elbow with an angle of 90 degrees or less, and we tap the triceps tendon just above the olecranon and notice the contraction of the triceps muscle and the tendency at extension of the elbow joint. We repeat the reflex on the opposite side by putting the arm in the same position and supporting it just under the elbow joint while tapping the triceps tendon just above the olecranon and noticing the contraction of the triceps muscle and the tendency at extension of the elbow. Then we elicit the finger jerks by intermingling the patient's fingers with our own fingers and tapping upon our fingers and noticing contraction of the flexors of the fingers. We repeat the test on the opposite side in the same position this way. Then we proceed to examination of the deep reflexes in the lower limbs. The commonest deep reflexes routinely elicited in the lower limbs are the knee reflexes and the ankle reflexes. The knee reflex or knee jerk is elicited while the patient's lower limbs kept in a position of flexion at the knee joints at right angle or obtuse angle and supporting both lower limbs upon the examiner's forearm, put in the popliteal fossa and tapping the quadriceps tendon between the patella and the tibial tuberosity. While observing the contraction of the quadriceps muscle and tendency at extension of the knee joint. We proceed then to examination of the ankle reflexes or ankle jerks. Ankle jerks are elicited while the lower limb is flexed at the knee and externally rotated, and we hold the patient's foot, dorsiflex it, and tapping the tendo Achilles while observing the contraction of the gastrocnemius muscle and the tendency at plantar flexion of the foot. We can do it this way, or we can do it while putting the foot on the opposite leg like this, and we elicit the reflex this way. We repeat the reflex on the opposite side in the same manner by flexing the limb at the knee joint and externally rotate it at the hip and dorsiflex the foot while tapping the tendo Achilles tendon and observing the contraction of the gastrocnemius muscle and the tendency at plantar flexion of the foot while eliciting the reflex. Then we proceed to examination of the superficial reflexes. The commonest superficial reflexes examined routinely are the plantar reflexes and the abdominal reflexes. In some cases, we might do cremasteric reflexes, corneal reflexes, and conjunctival reflexes. And in other cases, we might do gluteal reflexes. But in routine examinations, we usually examine the plantar reflexes and the abdominal reflexes only. Examination of the plantar reflex is done as follows. We hold the patient's foot at the ankle and we stroke the lateral side of the sole of the foot in a forward direction like this, and notice plantar flexion of the toes. We repeat the reflex on the other side in the same manner. Stroking of the sole of the foot is done by the handle of the hammer or by a key. This method of eliciting the plantar response is known as the Binisky method. There are other methods of eliciting the plantar response. Examples of such methods are the following. Oppenheim method. Oppenheim method is done by stroking the medial aspect of the tibia with the thumb in a downward direction this way. The next method is the so-called Gordon method is done by squeezing the calf muscle this way. The next method of eliciting the plantar response is the so-called Schaefer method, which is done by pinching the tendon Achilles, and we beat it on the other side this way. Yes. The next method of eliciting the blunter response is the so-called shadow method. Shadow method is done by stroking the lateral side of the foot below the lateral malleolus. Stroking the lateral side of the foot below the lateral malleolus. The next method of eliciting the blunter response is the so-called Gonda method, which is done by pressing down the fourth toe. And we bend it on the opposite side like this. Then we proceed to examination of the abdominal reflexes. The abdominal reflexes include the following: the epigastric reflexes, the upper abdominal reflexes, and the lower abdominal reflexes. Abdominal reflexes are elicited by stroking the abdomen from outward towards the midline, this way, and we compare both sides together. And we should elicit the epigastric reflexes, the upper abdominal reflexes, and the lower abdominal reflexes. Stroking of the abdominal wall induces contraction of the abdominal muscles on the same side with shift of the umbilicus towards the side of the stimulus. In pyramidal tract lesions, usually abdominal reflexes are either diminished or absent on the same side of the lesion. In some cases, we examine for evidence of pathological reflexes. The commonest pathological reflexes elicited in such cases are the following: the so-called sucking reflex. Sucking reflex is done by touching the angle of the mouth with the finger or with the handle of the hammer, for example. This induces a sucking movement if this reflex is positive. The reflex is positive in infants during the first year of life and in patients with diffuse lesions of the brain, particularly involving the premotor cortex. The next pathological reflex is the so-called snout reflex. Snout reflex is done by tapping the upper lip of the patient and observing the bouncing movements of the mouth. This reflex is also positive in the same conditions as the sucking reflex. The next pathological reflex is the so-called grasp reflex. Grasp reflex is done by touching the palm of the patient with the index and middle fingers of the examiner and moving them towards the tips of the patient's fingers. If the grasp reflex is positive, strong flexion of the fingers occur and the patient grasps the examiner's fingers. This reflex is positive in infants during the first year of life and in patients with diffuse cerebral lesion, particularly affecting the frontal lobes. The next pathological reflex is the so-called grouping reflex. grouping reflex is done by stimulating the side of the patient's palm, and we notice that patients with positive grouping reflex follow the examiner's hand and trying to catch it. This reflex is also positive in the same conditions as those with positive grasp reflex, sucking reflex, and smell reflex. Then we shift to examine coordination. Coordination is examined by the following tests. The so-called finger-to-nose test, which is done by asking the patient to extend his upper limb horizontally and to touch the tip of the nose with the tip of the index finger like this. And we observe any evidence of kinetic or intention tremors. And we repeat the test on the opposite side. The next test for coordination is the so-called finger-to-finger test. Finger-to-finger test is done by asking the patient to extend his upper limbs horizontally and try to touch the tip of one of the index fingers with the tip of the index finger of the other hand, and we observe any evidence of intention tremors. The next test for coordination is the finger-to-nose-to-finger test. We ask the patient to horizontally extend his upper limb, then to touch the tip of his nose, and then to touch the tip of the index finger of the examiner. This is known as finger-to-nose-to-finger test, and we repeat the test on the opposite side. And we observe any evidence of intention tremors. We should repeat finger-to-nose test and finger-to-finger test with patient's eyes closed, so as to differentiate between cerebellar ataxia and sensory ataxia. In cases of cerebellar ataxia, intention tremors occur whether the patient's eyes are closed or open, whereas in sensory ataxia, intention tremors appear only on closure of the eyes. The next test for coordination is the so-called heel-to-knee test. Heel-to-knee test is done by asking the patient to raise one of his lower limbs and to touch the knee of the opposite leg with the heel of the raised leg, and to move the heel on the medial aspect of the tibia in a downward direction this way. And we observe any evidence of intention tremors during this procedure. We repeat the test on the opposite side. In cerebellar ataxia, intention tremors occur on doing this test, whether the patient's eyes are open or closed. Whereas in cases of sensory ataxia, such as tabes dorsalis, intention tremors only appear on closure of eyes. The next test for coordination is the so-called rebound phenomenon. Rebound phenomenon is done by asking the patient to flex his upper limb at the elbow against resistance. And we suddenly release the upper limb and notice any rebound movement. In cerebellar ataxia, the patient cannot check the rebound movement of his upper limb on sudden releasing of the limb during flexion. So the examiner should put his left hand in front of the patient's face to protect it from being stroked by the upper limb of the patient on sudden release. The next test for coordination is the so-called adiadokokinesis or dysdiadokokinesis. Adiadokokinesis or dysdiadokokinesis means the inability to carry out alternate successive movements such as repeated supination and pronation of the hands and forearms. We ask the patient to alternately supinate and pronate his forearms and hands, and we observe the smoothness of movement. In cerebellar ataxia, such alternate rapid successive movement is usually slow and clumsy. We will proceed then to examination of the sensory system. Examination of the sensory system includes examination of the superficial sensations, examination of the deep sensations, and examination of the cortical sensations. Examination of the superficial sensations includes the following: examination of the pinprick sensation, examination of touch sensation, examination of temperature sensation. We'll start examining the pinprick sensation. The pinprick is either examined by using the pinwheel or by using a normal pin. Usually we compare pinprick on both sides of the body. We compare pinprick in the left hand with pinprick in the right hand, pinprick in the forearm with pinprick in the other forearm, pinprick in one side of the forehead with pinprick on the other side, pinprick on one side of the patient's cheek with pinprick on the other side, and pinprick on the patient's chin with pinprick on the other side. And we do the same comparison in the lower limbs, comparing pinprick on the foot with pinprick on the other foot, and pinprick on the leg with pinprick on the other leg, and so on. After comparing pinprick on the two sides of the body, we compare pinprick in the lower parts of the body with pinprick in the upper parts of the body. We compare pinprick in the foot with pinprick in the hand, for example, with pinprick in the face. And we do the same thing on the opposite side. And in every case we ask the patient whether there is any difference between pinprick on both sides or between pinprick on the lower parts of the body and pinprick on the upper parts of the body. If there is a side-to-side difference, we try to find out evidence of hemihypoalgesia or hemianalgesia. If there is a difference between bone break in the lower parts of the body and bone break in the upper parts of the body, we try to find out any evidence of a sensory level by testing bone break on the peripheral parts of the lower limbs, on the feet, and on the leg, on the thighs, on the abdomen, until we determine exactly the sensory level. We proceed then to examine touch sensation. We examine touch sensation in the same way by comparing touch on both sides of the body, and it's better to ask the patient to close his eyes and compare touch on both sides of the body, starting by the face, then the upper limbs, and then the lower limbs. And in every case, we ask the patient whether he is perceiving touch sensation or not. Touch sensation is tested using a brush or a piece of cotton or gauze. Then we shift to examine temperature sensation. Temperature sensation is examined using test tubes containing cold and hot water, and we ask the patient to close his eyes, and we touch different parts of the body with the cold test tube one time and with the hot test tube another time, and we ask the patient to tell us what temperature he is perceiving, whether it's cold or hot. And we compare both sides of the body together. We proceed then to examine the deep sensations. Examination of the deep sensations includes the following: examination of the vibration sense, examination of the position sense, and the examination of the sense of movement. Examination of the vibration sense is done by the tuning fork. We use a tuning fork of 128 cycles per second, and we put the handle of the tuning fork on the bony prominences and ask the patient whether he feels vibrations or not. And we compare vibration on both sides. For example, we start by testing vibration on the medial malleolus of one leg, comparing it with vibrations on the medial malleolus of the other leg. Then we compare vibration sense on the tibial tuberosity of one lower leg, comparing it with vibration on the other tibial tuberosity. Then we proceed to compare vibration on the anterior superior iliac spine. By comparing vibration on the anterior superior iliac spine on one side with vibration sense on the anterior superior iliac spine on the other side. Then we proceed to compare vibration sense on the clavicle of one side with vibration on the clavicle of the other side. We can compare even vibration on the mastoid process on one side with vibration on the mastoid process on the other side. In the same way, we can test vibration sense on the spinous processes, and we can test them over the phalanges of the toes or the phalanges of the fingers and thumb. And we can compare vibration sense over bony prominences anywhere in the body. As a matter of fact, vibration sense is the most sensitive test for posterior columnar flexion. That's to say, in mild cases of deep sensory loss, vibration sense is the most sensitive test for impairment of the deep sensations. The next test for deep sensations is the so-called the sense of movement. We ask the patient to close his eyes, okay, and we hold the big toe between the thumb and index finger this way, and we move it gently, and we ask the patient to tell us when the movement of his big toe just starts. And we repeat the test on the other side in the same way. The next test for deep sensations is the so-called the sense of position. The sense of position is done by asking the patient to close his eyes, and the examiner holds the patient's big toe between his index finger and thumb, and put the big toe in a position of plantar flexion one time and in a position of dorsiflexion another time, asking the patient each time to tell the position of his big toe. We repeat the test on the other side. In cases of sensory ataxia, such as teres dorsalis, position sense, vibration sense, and the sense of movement are all impaired. Then we proceed to examination of the cortical sensations. The cortical sensations include the following: tactile localization, tactile discrimination, stereognosis, sensory inattention or the so-called perceptual rivalry, and graphosthesia. We'll start by examining tactile localization. Tactile localization, that is the ability of the patient to localize the site of pinprick with his eyes closed. We ask the patient to close his eyes at first, then we prick him in one of his fingers and ask him to point with his index finger or the other hand to the site of pinprick. And we repeat the test on the other side. To test the ability of the patient to localize the site of stimulus exactly. In cases with cortical sensory impairment, tactile localization is impaired, so as the patient might point to another finger other than the stimulated one. The next test for cortical sensations is the so-called tactile discrimination or 2-point discrimination. 2-point discrimination is done using 2 pins and we're forming pinprick in 2 points with the patient's eyes closed, and we ask the patient to tell whether he is stimulated in 1 point or in 2 points. Of course, the patient's ability to perceive 2 points of stimulation or 2 pinpricks done at the same time differs in different parts of the body. For example, he can perceive 2 points on the dorsum of the hand or on the dorsal aspect of the fingers at few millimeters apart, whereas on the thigh, for example, he can only perceive 2 points of stimulation as 2 stimuli when they are apart from one another by maybe few centimeters. So the discrimination of 2 pinpricks done at the same time differs at different regions of the body. The most sensitive parts are the fingertips and the tips of the toes. The next test for cortical sensation is the so-called stereognosis. Stereognosis is done by asking the patient to close his eyes and putting an object on his palm and asking him to recognize this object. We can repeat the test on the opposite side using another object, asking the patient to close his eyes at first, and we put another object on the palm of his hand and we ask him to identify what object he is holding. Impairment of stereognosis is known as stereognosis. Stereognosis is the inability of the patient to recognize objects put on his palm. This occurs in cases of cortical sensory impairment. That's to say, in cases with parietal lobe lesions. Of course, cortical sensory impairment in parietal lobe lesions occurs on the opposite side of the body. The fourth test for cortical sensations is the so-called graphesthesia. Graphesthesia is the ability of the patient to recognize figures drawn on his palm. We ask the patient to close his eyes at first and we draw certain figures on his palm and we ask him to recognize the drawn figures. We repeat the test on the opposite side like this. If the patient is unable to recognize the drawn figures on his palm, this is known as a graphesthesia and signifies cortical sensory impairment, which also occurs in parietal lobe lesions, stereognosis and agraphoscesia, as well as impairment of tactile localization and two-point discrimination, all occur on the opposite side of a parietal lobe lesion. The last test for cortical sensations is the so-called sensory inattention or perceptual rivalry. This test is done as follows. We ask the patient to close his eyes and we pinprick him in one side of the body, and we ask him to identify the side stimulated, and then we pinprick him in the other side of the body and we ask him to identify the side of the body stimulated. Then we stimulate both sides of the body simultaneously in symmetrical points like this, and we ask him which side of the body we have stimulated. In cases of cortical sensory loss, such as in parietal lobe lesions, usually the patient is able to identify pinprick in either side of the body when stimulated separately, whereas on simultaneous stimulation of both sides together with the eyes closed, he omits the diseased side of the body altogether and recognizes only the healthy side. That's to say, he recognizes the pinprick on the healthy side of the body only, omitting the other side altogether. For example, if we have a right parietal lobe lesion, the patient identifies only stimuli on the right side of the body, omitting the stimulus done simultaneously on the left side of the body altogether. We proceed then to examination of the so-called stretch reflexes. Stretch reflexes are usually examined in cases suspected to have meningeal irritation or meningitis or meningoencephalitis or encephalitis or subarachnoid hemorrhage. Stretch tests include the following. First, the so-called Brzezinski neck sign. Brzezinski neck sign is done by flexing the patient's neck until his chin touches the chest wall, and we observe the movement of the lower limbs. In meningeal irritation of any cause, withdrawal of the lower limbs occurs on passively flexing the neck. That's to say, the patient withdraws both lower limbs with flexion at the hip and knee joints bilaterally. This is known as Brzezinski neck sign. The next sign for meningeal irritation or meninges or meningitis is the so-called Brzezinski leg sign. This sign is done as follows. We flex one of the lower limbs at the hip and knee, then we extend it at the knee joint. In cases of meningeal irritation for any cause, the patient withdraws the other limb. That's to say, he flexes it at the hip and knee to relieve stretch upon the roots of the spinal nerves. The next sign of meningeal irritation is the so-called Kearney's sign. Kearney's sign is done by basically flexing the lower limb at the hip and knee, then extending it at the knee joint. In patients with meningeal irritation of any cause, they usually experience severe pain on passively extending the limb at the knee joint. The next sign of meningeal irritation is the so-called Lassig's sign. Lassig's sign is also known as straight leg raising sign. It's done as follows. We raise the patient's leg extended in this way, and in patients with meningeal irritation for any cause, or patients with sciatica or prolapsed disc in the lumbosacral region, raising the extended leg produces severe pain. This is known as Lassig's sign. Then we proceed to examination of the skull and spine. Examination of the skull and spine is an important part of neurologic examination. Examination of the skull includes the following: inspection, palpation, percussion, and auscultation. We usually inspect the skull for evidence of hydrocephalus, microcephaly, acromegaly, or any other deformities of the skull. Palpation of the skull is done to search for evidence of bony defects of the skull or bony bushes, such as in cases of meningiomas with overlying bony bushes of the skull. And we should also palpate the anterior fontanelle, particularly in children. Percussion of the skull is important also in children, where we have to percuss the skull for evidence of the so-called cracked bolt sound, which is common in children with hydrocephalus. The last item in examination of the skull is auscultation of the skull. Usually we auscultate the skull for evidence of Berwick, such as in cases of angiomatous malformations or vascular tumors intracranially. The common sites for auscultation of the skull are the temporal region, and the orbits, as well as on the mastoid processes. We should also auscultate both carotid arteries for evidence of carotid Berwick, such as in cases of carotid stenosis. We proceed then to examination of the spine. Examination of the spine includes the following: inspection for evidence of deformities such as kyphosis or exaggerated lordosis or scoliosis or kyphoscoliosis, and also for evidence of spasm of the paravertebral muscles. Then we palpate the spine for evidence of localized tenderness or localized swellings. Then we test the movements of the spine by asking the patient to flex his spine and try to touch the tip of his big toe with the tip of the index finger, or to hold an object from the ground. This is a test for flexion and extension of the spine, and we can also test the movement of the cervical spine by basically flexing it and extending it and rotating it to one side and to the other side, and noting in every case the evidence of pain on movements of spine. We should also observe evidence of flexed rigid attitude, which is common in Parkinsonian patients. Then we proceed to examination of the patient's gait. We ask the patient to walk this way, and they observe his gait. Then we ask the patient to walk on a straight line with the heel of one foot in front of the tip of the toe of the other foot, this way, and notice any swaying during walking this way. We can also test the patient's ability to walk on the tips of his toes. Then we test his ability to walk on heels. Walking on tiptoes and on heels gives a good idea about the muscles of the lower limbs. Needless to say that general examination is of utmost importance in neurologic cases. General examination should include examination of the radial pulse, the temperature, and the blood pressure before examining the heart, chest, and abdomen. We should examine for evidence of lymph node enlargement in the neck, in the axillae, in the groins. We should examine for evidence of swellings all over the body. We should examine for evidence of skin pigmentation. We have to examine for evidence of thyroid enlargement. We should examine the breasts, particularly in females, for evidence of cancer breast or any swellings in the breast, as the neurologic condition might be a complication of one of such general systemic diseases. Thank you.
قال رسول الله صلى الله عليه وسلم: لا تشد الرحال إلا إلى 3 مساجد: المسجد الحرام والمسجد النبوي والمسجد الأقصى.